Hi, Arwa. Emad, hi. Muna, hi. Okay, I guess we are all set. It's almost 7 p.m. Arwa, you're online?
Yes, you hear me?
Yes, we can hear you. If you want to go ahead.
Okay. Shall we start?
Yes, we're sharp on time.
Sharp on time.
Sharp on time.
Good evening, everybody. It's our great pleasure tonight to have this great webinar. I think today's talk is very important in our lives, whether you're a periodontist, whether you're a implantologist, whether you're a surgeon or a general dentist. I think today we're going to be really talking in this important topic about the use of the piezotome in our surgical procedures. Our great guest, well known, I don't have actually to introduce him. I'll leave him to talk about himself briefly. Dr. Alain Romanos from Lebanon, well known. He's really, like, I mean, you see him everywhere. Almost every month he has a webinar. A great speaker. Best friend of ours, I think, and I'll just leave him with the mic.
Thank you, Arwa. It's a great pleasure to be here with you guys and to share this panelist with such a prestigious group of speakers from all over the world, and especially my dear friends from Arwa from Saudi Arabia, Emad from Syria, Muna from Jordan, Bassam from Egypt, and my dear friend Luis from Portugal. And I want to thank Tony for hosting us. Dental News, well known in the Gulf and the Arab world, and really this has been a pleasure to be here. And I think we're in Lebanon. We're going back to a lockdown for another 2 weeks, so probably I'll be doing some more webinars. The topic that I chose to discuss with you guys tonight is talking about techniques, minimally invasive technique in our daily practice. And one of the things that we're using in our practice is using the piezosurgery. You know, I miss being on stage, to be honest with you, and I miss being with my friends and sharing this knowledge and talking to colleagues and learning from each other. I'm here with my team. We collected all these cases, the videos. I'm thankful to this team because they did most of the job. You can follow us on these platforms, the Facebook and social media platform. If you guys have any questions, you can always come to me and I'll be more than happy to answer you. You know, we as a clinician, we always have a primary objective, and I always like this slide because this is how my philosophy is on a daily routine. Is I want to be predictable, I want to have a long-term stability results, I want to do things with less number of complications and less number of pain and swelling and bruising. And of course, my secondary objective, if I can do as many surgery at the same time, patient will take one time the medications, the swelling, the pain, they shorten the healing time. And if I can do all this in a cost-effective way, and this result, I will get a happy patient. So being predictable and minimally invasive are the key to success. And today, we have in the literature a good scientific documentation and evidence that we can get there. If you look how we used to do external sinus lift, I remember my dear friend Emad used to tell me, you know, when they used to do external sinus lift, Dr. Barakat, on all the, you know, when they started doing this, mainly they used to use autogenous bone graft. Today, I can tell you we're almost using 100% biomaterial. So we're being more and more less invasive to the patient. I used to do a lot of chin graft, to be honest with you. Then we switched slowly to the Ramus. Then we switched slowly from the Ramus to doing allogenic block and xenogenic block graft. We can still do, of course, the autogenous, but we're moving more and more toward guided bone regeneration. And all this in our mind, why we're doing this? Because we're being predictable with this technique and less invasive. Cases that they needed orthognathic surgery, today we're trying to handle these cases with Botox and filler. Why? Because patients refuse to go through heavy surgeries. Free gingival graft, to be honest with you, we're doing less and less. The big chunk of free gingival graft, the big thick ones, we're doing more smaller tissue, thinner tissue. Then we switch sometimes, if we can, to connective tissue graft. And if we can use donated tissue or allograft material, or even tissue engineering or PRF, or anything that can help the patient to heal faster and less swelling, then people are going toward this technique. So we live in a world of a minimally invasive surgery. Now, one of the things that we can do in our daily practice is using the piezo. And the question is, why do we use the piezo? Well, because it reduces the number of complications. You have less swelling. In my experience, I have less bruising and less swelling. Patient comes with less complications. Of course, you always have some patients respond differently to all type of surgeries, but you will experience less of these complications with this device. You will have less bleeding if you're doing external sinus lift, and we will talk about this. And of course, patient will take less painkiller, number of painkillers. And if you do all this, at the end of the day, this is what makes your patient happy. Happy patient will give you a good testimonial.
فزينا ضحكتك جراستا.
They will send their families.
أنا بدي أقول شغلة عن ضحكني عن جد إنه قبل كانوا يقولوا لي ابتسمي أعمل هيك. ما قدر ابتسم ما في خبرة كيف كانوا.
The difference between you and the dentist next door. So going back to history, and when you look at the history of piezosurgery, it all started back in the 50s. Till 2001, where Professor Versolot introduced the first combination of the sound and this technique. And the first human study was published in 2000 on a split ridge bone augmentation. And the property of the piezo, it's that has this ultrasound modulation that cuts precisely and safely in terms of 25 to 35 kilohertz. And what makes it safe is that it's selectively cut through the mineral bone structure, which is less than the soft tissue. Because in order to cut the soft tissue, you need more than 50 kilohertz. So what's amazing is that this device, and this has really amazed me when I first looked into it, and my first piezo was back in 2003, 2004, and I have 3 piezos since then. When with this device, you can cut this big chunk of bone, but when you take this insert and put it on your finger, you cannot even cut your finger. So this really amazed me how this technology were able to go that further. So the question is, why do we use it? Well, because it gives you a precise surgical precision between the piezo and other burrs. It respects the soft tissue, which makes things safe for us as a surgeons and as a dentist, because you don't have, when you get to the soft tissue, whether it's a nerve or a sinus, there's no risk of tearing. It will not cut even when you get too close to the soft tissue. It gives you a nice clear field of view, and this cavitation effect, the cavitation effect will reduce the hemorrhage, especially in cases where Dr. Emad will tell us about the 4-1 and 2. Sometimes you have a lot of bleeding. I don't do them, but Dr. Emad Salloum have his experience. You have less hemorrhage when you use the piezo. And if you're using, the piezo, the new generation today, you have high luminosity, the effect of the irrigation, lack of vibration, which makes things really nice on the patient, less stressful on the patient. There's this vibration effect on the patient's head. Plus, it's so light, the weight of the handpiece is so light comparing to other devices. So for us as a surgeon, it reduces the anxiety, surgical fatigue, and of course, we have a more comfort patient. So there's so many reasons why we should use it. The second question is, when do we use it? Well, if you look in the literature, there's so many indications for that. The main ones, if you're doing sinus lift procedures, whether it's external or internal. Or if you want to do ridge split, and I think you cannot do ridge split today if you don't have the piezo. It makes your life much easier. Extraction, I've been using it more and more lately, especially for complicated wisdom teeth, using it as this device to be safe and not to get into the lingual nerve. In periodontal therapy, I'll share with you my experience with that. Again, I'm using because it makes things easy to remove in one piece without granulation tissue. Other indication, you can use it in orthocorticotomy to make your treatment faster. You do these small incisions with a small ostectomy to speed up the process of the ortho treatment, or even to collect bone, autogenous bone. And if you're doing bone grafting procedures, we all know today that you need some autogenous bone graft to your graft. Implant site osteotomy, or you're using apectomies. If you're doing any root canal surgery, this a great indication in these cases as well. I do not do inferior alveolar nerve lateralization, but however, I can use the same window technique sometimes to remove implant if they've fallen in the sinus or in the lower mandible. But this is, again, another indication to do that. And today, we're all doing a lot of implant removal. It's becoming huge in my practice, removing implants. And if you want to use burrs, or if you want to use, the Trifine, you will be removing a lot of autogenous bone as well. So piezo is a nice tool to remove implant as well. So you have this 11 or 12 indications. I will focus in the next half an hour on these topics: sinus lift, the extraction, the perio treatment, and the bone harvesting technique. When it comes to external sinus lift, well, we all know doing an external sinus lift today, there's two major complications from that. One is having a tear in the membrane, two, the bleeding. And with the piezo, you have a nice cut, you have a nice window. You can make a small window in order to do your graft. And when you look at this case, really, things are nice, neat, and really no bleeding, no swelling, very safe. And the advantage of the piezo, because we know from the literature and from these two major systematic reviews, the New York group, Dr. Wallace, and the Milan group, we know that on average, the perforation of this membrane is about 25 to 30% perforation of the sinus membrane. So this is really high, 25 in our daily practice is really high number. And some of these cases might cause some sinusitis or some infection in the sinus. So how can you avoid these small perforations? This is one issue, especially in some difficult anatomical sinuses where you have the osteotome, the risk of perforation is increased. Now, the good thing today, if you have a CBCT, and you have to have a CBCT before your surgery, that in majority of the cases, you can see the artery on the CBCT. So when you're doing your window, you can avoid hitting this PSA artery, the posterior superior alveolar artery. And we know the second major complication, or the second issue with the sinus is the bleeding. Sometimes you hit this artery and you have really big time bleeding, which makes your surgery difficult, and patient may get bruising. And you can see this artery, when you do the window, you can see sometimes going through the soft tissue and going through the bone. So to make your procedure safer and cleaner, and with the piezo, you can have this nice cut. You can remove the lateral window and replace it at the end of the surgery. And this has been published extremely well in the literature. And it seems to be preferably for the conventional technique. The nice thing about it, the outline that you can do with the burrs, the lifting of this membrane, and repositioning of the bone at the end of the treatment. And when you look at this study, why this has been an advantage comparing to the conventional technique, you look at the drop from 30% to 7%. 7% perforation. So you have almost 23% of improvement when you use this technique. And in the article of Wallace, all the perforation happen when you're trying to elevate manually with the curettes the sinus membrane, not while you're doing the window. So really, it's nice to use it because it reduced tremendously the perforation frequency, even with the limited skillful surgeon. So for people who are start to do sinus graft, this is a great tool to have. And all what you have to do is these 3 steps. You have to use the osteoplasty, then ostectomy. You separate the membrane with these burrs, do your sinus elevation, put your bone graft, and then replace this bone. And the beauty of this, you can do smaller and smaller of windows. The smaller the window, the more osteogenesis properties, the more contained defect you have, which makes your healing faster, shorter time, period of time, and better bone density. So let's take, for instance, a case like this. This is Joe. Joe has bilateral sinus lift, and you can see there's a septum on this side. And we decided to do an external sinus elevation and look at how big is the window. Really, we do today smaller and smaller windows. And when you elevate, you know, when you have a septum, chances that you're gonna have a perforation are really high. With the piezo, you can avoid this perforation by doing this sinus elevation. And we did, in this case, a GBR at the same time. So this is how we do it. We always have a CBCT, pre-op CBCT, post-op CBCT. We always work with CBCTs. And this is Joe. We get him a week before the surgery, get him cleaned up, put him on chlorhexidine, antibiotics, and then the day when we do the surgery. So this is how we present the case. Straight line incision, full thickness flap. It depends. Some cases we do a vertical incision, sometimes we don't. We use these tips, and each tip has, you know, you have to know the frequency that you have to adjust for your procedure. And this is how we start. We start to draw the outline of our window, and we make really, I'm doing smaller and smaller windows nowadays. Once we have this bone connected, we start to elevate the membrane using the de-attachment burr, which detach the membrane from the bone. We always start on the sides, mesial, distal, then the medial wall, and then we lift the whole thing manually with some hand carets. But the biggest job is done here at this point, while you're using these burrs or these drill, and then we switch to the manual, and things become so easy. Here, it's a matter of just filling in the sinus with the sinus lift. We check the perforation. We use 100% xenograft in the sinus. We pack completely the sinus. Of course, if we can replace the bone window, it's better to replace it. If not, we always use membrane. It happens in this case, we were doing combination of external sinus lift and a GBR using collagen membrane. So this is the case after the post-op CBCT. And you can take the case from, we did both sides. This is the right, this is the left, and this side we use some pins. And you can compare the CBCT before and after. And again, you know, these cases, patients are really happy, no pain, no swelling, and really less complication. Implant site osteotomy in cases where you're doing internal sinus lift, and this is how we used to do it. We remove the roots, we prep the teeth, and we take an X-ray. In cases where you have 4 to 5 millimeter, we do the elevation internally. If you want to do internal sinus lift, of course we can use the osteotome technique, but if you use the osteotome technique, we can lift the sinus. In these cases, you have to use the hammer. So if you want to use the hammer, the problem with these cases is sometimes the swelling, the bruising, and some patients get dizzy after this procedure. So the hammer really is in some of these cases, even if it's an internal sinus lift augmentation, sometimes the patient comes back with this bruising. So the bruising is an issue. The question is, can we do the same thing with the piezo? Well, you know, the piezo has this cavitation effect, which induces this hydropneumatic pressure on the membrane, which elevates the membrane, sinus membrane, and then easily you can introduce your bone and the implant. The beauty of these tips comparing to the drills, and there's so many studies that were done on that, The drills, it eats up the bone, and there's this high activity of osteoclast comparing to the piezo surgery. The piezo, what they found in these studies, that you have a higher primary stability when you place your implant, and the reason why, because you're removing less and less of bone. And this randomized clinical trial on 30 patients, they compared the conventional technique to the piezo, and what they found that you have less trauma on the bone with the piezo, which makes the healing period shorter, and the ICQ, which is the primary stability of the implant using the piezo, is much higher than the conventional technique. Another study that was done looking at this again, that result that there's less traumatic osteotomy with the piezo, favorable wound healing, and decrease of microfracture of the bone. Another study, interesting study, a systematic review and meta-analysis, all showed that you have a higher ICQ, or higher primary stability with the piezo. And the second question, of course, the drawback of the piezo using this technique is the time. It takes more time comparing to the drills. And when you look at this, is interesting studies when they looked at 38 implants. One side they used the piezo, the other side they used the burrs. And when compared, they both groups, the piezo surgery group showed less osteoclastic activity, so there's less bone resorption. The second thing, when comparing to crestal bone loss, both showed the same crestal bone loss. So there's not much advantage in terms of crestal bone loss. The pain was less in the group of the piezo. And this is what made the difference. People, when they filled in the VAS score, they had more pain, more trauma on the side of the conventional technique. So on a molecular level, it seems that the piezo has less trauma in the osteotomy side. This is another study that shows in soft bone or in type 3 bone, it's better to go to the piezo. In type 1, type 2 bone, I will combine the burrs with the piezo. So really, it's a clinical feeling and a clinical experience that you get after you use this so many times. Another study, when they looked at a split mouse, one side again using the conventional technique, the other side using the piezo. Look at the painkiller. And when you look at this drawing here, you have less number of painkiller on the side where they use the piezo, on the group when they use the piezo, compared to the group where they use the conventional technique. So this is how we do it today. We have these burrs and we go in sequence. I can tell you it takes more time, definitely. Definitely it will take more time than using the conventional technique. But, this is an implant that should last for at least 15, 20, 25 years. So taking extra 5-10 minutes and being cautious, being safe, sometimes, honestly, it's worth it. I can tell you, you have to have your day to be patient. And if you're patient, this is the way to go. If you're in a hurry, don't use the piezo, because, you will not handle because you have to switch from burr to burr, and then it takes some time to drill or to prepare your osteotomy. But the beauty of it is once you pass the bone and you hit the soft tissue, this is not gonna tear the soft tissue. So you can feel it, and then you can take your bone and start to add this bone into the site. So this is the beauty of it. It's safe, makes your procedure really safe, maybe a bit more time, but you can prep. There's no hammering, there's no tapping on these patients, and really they don't like the vibration effect of the burrs. So here we place the implant immediately at the same time with the internal sinus lift. And you can see most of these cases, even when we have soft bone, even when we have type 3 and type 4 bone, if you're under prepping your site, you have a high primary stability. And here it was a 2-stage implant, and this is the case before and after implant placement. Another indication for the piezo in endo cases where you have a cyst, you can come apically and remove the cyst, or you can you section part of the root. But when you use the piezo, the nice thing about this is you don't have to do apectomy. With the tips that you have, you can prep the root from the apex and then just fill it. So one of the advantages when you do the retrograde surgery, it cleans the walls because you can remove the cyst in one piece without having any granulation tissue. It reduces the smear layer volume, and no need for root sectioning. So you don't need to shorten the clinical crown height. So by cleaning, removing the exposed, from the apex with these small tips, you can get to a good preserving the root and removing the cyst. This is a case where this patient had these three crowns. She did not wish to remove her crowns because she just had them done almost 3 years ago. And when you look at the 2D X-ray, you cannot see much of the cyst, but she was experiencing some pain. And when we took a CBCT, you can see that there's some periapical lesion at this point. And here, crown was still okay in terms of the margins. So we decided to go ahead and do a pectory. I can tell you this is a really weak tip. It's a very thin tip. So when you use it, you should be really careful because it's so easy to break. And it's not, it's an investment if you break these tips. So here, this is what we did. We removed the cyst and then we cleaned the apex, fill it with MTA, added some bone graft, collatate, and then sutured this back up. So really in apectomy cases, this is beautiful. It's easy and especially in short roots. You don't want to, if you don't want to compromise these length of these roots, you can use these tips to remove the cyst. And the nice thing is when you do your window, you can remove the tips. Actually, the whole cyst comes in one piece without tearing apart these granulation tissues. So here, this is after we clean the defect. And you have to use these two small tips, the small tips that goes from the bottom without sectioning the roots, and remove some of the gutcha percha, and then we place MTA in these cases. And then in some cases we do use bone graft, some cases depending on the case actually. So here, this is after we clean the root, and MTA, bone graft, and suture priming. So really, the other advantage when you do this, there's not much of a bleeding. And especially when you try to put MTA, you want to have a dry field. And this is the cavitation effect of the piezo makes things less bleeding. So this is after we place the membrane and suture. Another indication is extraction. Well, I'm amazed because when I was looking at the literature, when you look at the last 2-3 years, so many publications on tooth extraction. And this is one recent article, 2018, on the 5 randomized clinical trials when they tried to remove wisdom teeth using a conventional technique versus piezo. And what they found that, they found that the pain, the swelling is much less than when you use the piezo. The third finding, you have less frequency of having trismus or a limited opening in the mouth. So in these cases, when you look at taking wisdom teeth out, of course, depending on the difficulty of the wisdom teeth, but the trismus is much less in the opening of the mouth. After 1 day, you have at least 5 millimeter more opening with the piezo group comparing to the wisdom teeth using the burrs. And not just that, the pain score at 6 and 7 days was much less in the piezo group. So less pain, less swelling, and more mouth opening and less trismus. These are the main advantages when it comes to removing wisdom teeth, especially in cases as well when you have to remove root tips and when you try to remove teeth that they are really close to the nerve. It happens that this patient had the combination of extraction of wisdom teeth along with the connective tissue graft. So instead of using the burrs, we can use these drills to do your osteotomy. And I use these as well if I'm using the block graft. I can combine my wisdom tooth extraction with harvesting a block graft. So here, you're doing this safe, no worry about any artery, about any nerve. And another thing I found, honestly, is that when I do my soft tissue graft, I can use the tips of the piezo to do my flap elevation, especially in cases where you have the thin tissue or when you have a scar tissue. So in cases where you have difficulties of elevating your flaps with the boozer or any type of elevator, the piezo could be really a nice tool to elevate your flap, you know, and do your procedure, whether you're doing a soft tissue grafting technique or any other technique. So using the piezo for flap elevation, it's not been published in any article, but it's just a clinical finding, a small tip that I can share with you. In this case, I was doing a free gingival graft converted into connective tissue graft to do root coverage on the lateral. And this is a procedure that we combine the extraction of the wisdom tooth along with the soft tissue. Today, I'm using it more and more in my periosteal surgery and aesthetic crown lengthening. Instead of using the burrs, I'm using more and more the piezo, and this way it avoids you to hit the roots or to hit the dental anatomies. So in perio treatment, another finding, and this is again a clinical finding, if you want to use it for cleaning or scaling root planning, and this is just my expert opinion, I found that you have less sensitivity when it comes to using these tips doing the cleaning instead of using the regular ultrasound. So this is the case where we've been using, it takes a bit more time, of course, but for patients who have high sensitivity issues, who are really sensitive to these ultrasound techniques, using the piezo for these patients instead of giving them anesthesia, this could be the answer for these patients, especially for sensitive patients. So you can use these tips as well to do it for just a regular cleaning. There's many different anatomy, and this is the beauty of it, that for furcation areas, you have the sort of neighbor angulation of these tips where you can get into the furcation or under the bridge, have access, because sometimes the curettes are too big for these spaces. And especially for patients who have veneers, excess cement, this is again could be a nice indication. The last indication that I will share with you tonight is the bone harvesting. And this is what I do use it most of the time. Well, doing your block graft, and you know, if you look into the literature, you know, we know that blocks still has some indication today in our daily practice. Of course, when you compare the piezo to the burrs or to the micro saw, all the studies have shown that the micro saw is the fastest. In 5 minutes, you're done. You have to add at least another 10 or 15 minutes if you want to use the piezo, comparing to the study that was done as a split mouse. So you have more time if you decide to use the piezo comparing to the micro saw. When it comes to the implant site preparation, of course, piezo gives you a much safer procedure. And when you look at the complication rate when it comes to doing the ramus versus the symphysis, you look at the ramus has more complications in terms of temporary paresthesia, 26 to 0%. And when you look at comparing in the piezo group, 0% in the ramus, symphysis 28 versus 3. So 3 is temporary, and most of these cases, of course, there's no permanent paresthesia afterward. So when you look at the numbers, burrs 28% versus 3, this gives you a great comfort to you as a surgeon, because these are not an easy procedures to have, and you know it's much stressful on you as a surgeon. So decreasing the paresthesia rate, decreasing the complication, it's really needed in today's practice. And again, harvesting some of the autogenous you can use the scraper, but you can use as well the burrs, or you can use the piezo to harvest autogenous bone from implant site or from next to the implant site or from the tuberosity areas. But again, it gives you a good volume of bone cells that can differentiate into osteoblast. And we know that after taking teeth out, we know that you will have some bone remodeling. Patients wait sometimes too long to do their implants, or they have periodontal disease, they wait, they lose bone, or they have surgical traumas, which gets you to a huge defect. Or sometimes, and this is what I'm seeing today a lot, patient with implant failure, peri-implantitis, You see this patient, after many years, and you have to build this whole ridge again because there's no bone to work on. Or sometimes patients who have congenital missing teeth. And we know there's a lot of classification in the literature in terms of bone defect. We know those type 1 defect are easy to handle. You can place the implant, do maybe connective tissue graft. In the type 2, you can maybe still place the implant and do some GBR technique. Or in cases where it's a little bit more advanced, in these cases, you have to place your implant prosthetically in the ideal position. So you have to do some build-up and some ridge augmentations in the class 3 and class 4. And we know today in the literature, you have so many different techniques to build back the bone. All the question is, how do you feel comfortable in which technique? You can be using the GBR, you can use the split, you can use the block. All these techniques are available to grow bone. And depending on how much bone you want, this is what I do personally, depending on how much bone I need to place my implant in a proper position, I choose my technique. And of course, bone graft using blocks, there's so many articles that support this technique, even though in some cases you will have some remodeling and some resorption of the graft, but we all know that implant survival rate is so high in these bone grafting technique. And what we tend to do today, we tend to over contour these sites when it comes to placing implant. This is, if you look at this case, this is a mild to moderate defect. This is Janine. Janine, she's young, she's 24, she had the trauma and she lost the lateral. When you look at the CBCT, it shows that she has not much of a bone width. And it happens that at the time, Janine needed to remove her wisdom teeth at the same time when we tried to combine these procedures. So I decided to do extraction of wisdom teeth, and this is the one-time surgery, one incision. You make your flap, you remove the wisdom tooth, and then while you're doing it, you harvest the block and place it as a block. I always try to do one vertical incision if I can, 2 teeth away. Sometimes I have to do 2 vertical incisions depending on the case. And this is when we take the wisdom tooth out and we harvest the block at the same time. So we do it in combination in one-time procedure. Fixate the block. The rest of the block, which is this part, we harvest it and we crush it into small particles. I always like to add some xenografts and a membrane because one art study and others shows that when you do this, you have less resorption and less remodeling at the time of implant placement. 4 months post-op, patient came back, we placed the implant and you can see the amount of bone we gained. We waited another 2 months, another soft tissue procedure. This is the implant placed. And here I harvest the connective tissue graft, place it into my healing abutment, and then just to bulk in the soft tissue a little bit. And this is the prosthesis 1 year post-op. And you can see the implant stability 3 years post-op. So in these cases where you can combine autogenous bone extraction of wisdom teeth at the same time while doing your bone graft, this would be beautiful. And you have the patient at least suffering one time, taking medication one time, and going through this in one time. This is a case of Yara that I did with Dr. Nadim, who's present here. We did a combination of perio-pros ortho case, and this is after Dr. Sabri finished the ortho treatment. So when we looked at Yara after the final treatment, you can see that she's missing some bone. And in order to place prosthetically our final crowns, we had to do some bone augmentation. And this is Yara. She has 2 sides, congenital missing lateral on number 12 and on the lower incisors. And when you look at this CBCT, it's really a knife edge CBCT, whether it's on the top or on the bottom. So when you flap this and you look at this ridge, and you start to wonder what is the best site to harvest autogenous bone graft to Yara without being really traumatic and trying to be really minimally invasive. And what I decided to do here, I decided to harvest with the piezo. And you can see the nice cut with the piezo comparing to the burrs, and copy paste, just take this block, harvest it, crush it into particles, and then take it from here to here to do my ridge augmentation. Because it's the same incision, same site, same procedure. And this is what we did. I used a crusher and I used some bone scraper, and then use complete just 100% autogenous, start fixate my membrane on the lingual side, place the bone, perforate, of course, for more osteogenesis, move my membrane, put all the autogenous bone graft, and in the donor side, just put xenograft to fill this gap. Fixate the membrane, and this is after we suture the procedure. So for Yara, it was really nice to do it in one shot, one time, one incision, copy paste from the same side to the side. The lateral, we had some autogenous bone left from harvesting, so we used the same time at the same day, same technique, guided bone regeneration using collagen membrane, tissue tags, 2 buccally, 1 palatal, and this is after months. When you look at the you can see how much we were able to grow bone, and where we harvested, we filled it with autogenous. 5 months post-op, she came back, Yara came back, and we were able to place our 2 implants in the ideal prosthetic procedure. And you can appreciate how much bone we were able to grow in just 5 months using Yara's autogenous bone. And, you know, really, the amazing about this procedure, the amount of pain she had, almost none. She just had to take painkiller for the first and the second day. No swelling, no bruising, no pain. At the implant placement, we tend to do a second mini GBR on the top of the implant just to avoid these resorption. Second stage was done after two months. And of course, this is the final prosthesis. She's almost 6 or 7 years out now. This is the final prosthesis. So this is the implant. Dr. Nadim did the veneer here, bleached the other teeth, and this is the 2 implant supported crowns. So you have an implant, a natural teeth, a veneers, and this is the final prosthesis. So the clinical implication of using piezo and block graft is really tremendous. This is another case where this patient needed implant on the molar side and needed a soft tissue, a bone graft on this side. So with one anesthesia, one incision, you can do all in one. Implant placement, harvesting the autogenous block, and look at the cut with the piezo. It's so nice because you can place your block, fixate it. And if you gotta use a burr, I mean, you know, you will remove at least 1 millimeter of bone, plus the vibration effect on the patient, it's not really nice. So having this using the piezo in these cases is really nice. So you crush the autogenous, place it on the top of the membrane, and this is after 4 months, come back and place my implant with a good amount of bone surrounding my implant. Another case, another clinical indication, this patient had a failing lateral. And when you look at this case, it happens that this patient had a lingual tori. And not just the lingual tori, but he needed some crown lengthening on these guys here. So we tried to combine things at the same time. And of course, removing the lingual tori, using this bone as an autogenous bone, and cutting with the piezo, it makes your procedure so easy. And instead of throwing this away, you can use this lingual tori, crush it. Of course, you don't want to crush this on the next to the patient. You better go to a different room and do it, and use the pure autogenous, just autogenous, no xenograft, nothing. Place it as a GBR membrane with a connective tissue graft. So this is 2 weeks post-op, and at 5 months, patient came back. I can tell you this bone quality was almost type 1 bone, very hard bone. Look at the amount of bone we were able to grow, and this is the implant that was placed. We always try to improve the soft tissue quality. This is, we did the mini VIP CT, taking the connective tissue from the palate, rotated, leave it for 2 months just to improve the quality of the soft tissue. And then after 2 months, this is the restoration. And when you look after 3 years, look at the bone still on the top of my implant. If you have your implant placed properly, and if you have a good bone quality and quantity and a good soft tissue, you can tell that this implant is gonna last the rest of this patient's life. So the advantages of the piezo is really the surgical precision comparing to the burr. You can really make your specific design. It respects the soft tissue and it will not cut the soft tissue, especially in areas where at risk, the inferior alveolar nerve, the mental nerve, or the sinuses. It really makes you safe. You feel safe when you do it. It gives you a nice clear field of view, so you have not much of a bleeding while you're working because of the cavitation effect. It reduces the hemorrhage, and I will let Emad comment on that at the end of this lecture. Another advantage is the the piezo, the weight. When it's really lightweight. When you handle this comparing to the handpiece, really it's really nice. The post-op healing, I can tell you my clinical experience, I have the feeling that patients they have less swelling, less bleeding, no risk of emphysema because there's no air. When you use this air drill or the high speed, sometimes you have emphysema, which you don't have in this technique. It decreases the post-op pain. Studies have shown you people take less painkiller comparing to the burrs. Another advantage, of course, the irrigation effect, the lack of vibration, which makes your patient, especially the stressful patient who are anxious, it makes this a nicer experience. Reduce anxiety, surgical fatigue, makes your patient more happy and more comfortable. Disadvantage, well, time. You can see this in every article I read about the piezo. They all talk about the time, comparing to the microsaw, comparing conventional drilling. Of course, it takes more time because, if you want to be safer, you have to go through these steps. The second thing is irrigation. You have to have really high irrigation. You have to keep your site moist and this cavitation effect to avoid the overheating. While the burrs, sometimes you have to change these inserts, and sometimes they broke, and they're not cheap. It's an investment that you have to do. You cannot sell this to the patient because it's an added value in your practice. It's not like the bleaching machine that you can make money out of it, but this is a high-end procedure and safer procedures in your cases. You cannot use it in patients who have pacemaker. Adequate dexterity, of course. You have to be careful when you use it. You cannot put so much pressure because the more pressure you put, the risk of breaking these inserts is high, and the overheating, of course. In cases, I do not do these osteotomies and the orthognathic surgery, but it seems very difficult to go in these deeper osteotomy. I am on time. We finish in 15 minutes. This is our platform. Any case you guys have any questions, I'll be more than happy to answer them. I will finish this lecture with a quote that we all make a living by what we do in our daily practice. But sometimes these small little things that we do to our patient, less pain, less swelling, less bruising, this is what makes the whole difference in our daily practice in 2020. Thank you, Tony, for hosting us, Sean, Arwa. I'm really looking forward and so excited to share the panel with my friends and share their experiences. And I'll probably Arwa have something to say because I know Arwa has more than I do experience. I've been using it since 2000, I would say 5, maybe 6. You've been using it for the last 20 years. Thank you.
Thank you very much, Dr. Romanos. It's really wonderful. You give us a nice presentation talking about the variable uses of this great tool. Actually, I basically, personally, I cannot start the clinic without having the piezo on the table before I start, because in each step and each procedure, you will find a use for it, from removing calculus to taking an autogenous block graft. It's great, but with the, some important tips I found sometimes in some of the companies, when you do extraction, atraumatic extraction, the tip is so thin, so it might break. It might break while you're trying to release the periodontal ligament from around the tooth, particularly removing wisdoms or impacted teeth. So you have to be very precautious When you do this, so it doesn't break, because sometimes if it breaks and it goes deep, then really it will be a nightmare to remove it without harming the socket, particularly if you're doing, for example, socket preservation or automatic extraction for socket preservation. So this is the first one. The second thing, that you should not touch the buccal bone at all with it. I've seen some people, they go all around it, like, 360 degree. And if you fracture or crack the buccal bone while you're planning to put an immediate implant, that will be a problem. The other thing, as I told you, I personally use it in each step. I found it very useful when you do the split crest, because it has demarcations, and then where you want to decide to put your implant or the length of the implant, you can go with the piezo, with that arm, and go just back and forth, and that will give you an excellent split crest, where you can even place your implant at the same time. So
I think you cannot do split ridge technique without the piezo today.
Yeah.
Luis, my friend, is online.
Hello.
With us. You have more experience than we do. We need your opinion on the piezo.
Hi guys, it's a pleasure to be here once again with all of you. Hi Emad, hi Dr. Harna, hi Per. I'm sorry I was a little bit late, I was finishing one surgery. Well, my experience with piezo, it's a tool that I use on the daily basis. I use it mostly for all of the indications that Alain showed during the presentation. The recuperation of the sensibility for the patients that we use the piezo to make the sagittal split, it's very different when we use burrs like we did in the past.
Emad, I know Emad is a big user in orthognathic surgery. He used to use it. You both guys do this.
Yeah, Louise now, yeah.
Emad, give us your comment.
Hello, everyone. It's so good to see you all. Arwa, Louise, Alain, Bassam, how are you all?
How are you?
It's good to see you. I'm fine. Well, each of us has his own experience. Maybe for years and years, I've been using piezo now for about 15 years. Maybe I was one of the first user in my area. Well, I use it on a daily basis. As Dr. Arwa said, is my right hand tool. It's like the handpiece. It's like the micromotor in every surgery. I think from my perspective that most of the dentists or even the oral surgeons now are using it mainly for anything related to the advanced surgery for, I think, implant surgeries. Any advanced clinic in implant surgeries should put in their mind that piezo is one of the most important devices that should be obtained and put beside on their table. They use it for starting from atraumatic extraction, as Dr. Arwa said, that it's one of the main instruments for atraumatic extraction, up to the level of obtaining bone harvesting procedures. Of course, I started to use the microsaw of Dr. Professor Khoury. I've been using it for quite a long time. I just want to mention something related to what Dr. Alain said about that all the rotary instruments are a little bit faster. I agree with him. But when you start using the piezo, especially the good devices, you will see after a learning curve, you get a learning curve by using the piezo. And at the end of the day, you find that there is almost no such difference between the time you take for doing it in piezo surgery or the rotary instruments. The main advantage, I think, that no rotary instrument, not even the very thin saw, microblade saws, would give you a clean, neat, bony cut like the piezo. Second, it's the only device that you could apply in very narrow areas, like between two adjacent teeth. There is no way to do bone splitting in narrow ridges without using a piezo device. But as I mentioned, that there's a learning curve for each device or each technique you use day after day. At the beginning, I find it Well, especially surgeons, we are always in a hurry, and we are used to use the macro surgery. But when we are involved in implant surgery, we learn something, that we are in a marathon, we are not in a race. So it's very important that to start using the piezo and take this learning curve step by step. And I'm sure after 1 year at most, you will get the tactile sense of how to do the pressure on your tips for each device. And at the end, you will be able to do the same surgery with the same time. I think so.
Thank you.
I guess I could have something that's a common error of people that start using piezo, apply too much pressure. And you know that the tip of the piezo is doing this by itself. You just need to slow, gentle, and let the piezo work for it. Yes.
Absolutely. If you apply more pressure, as Dr. Arwa said, so you are putting your instrument in a very high risk of fracture. This is first. Exactly. And it will not give the same cutting effect. If you over increase the pressure, the cutting effect will be less. So it's a kind of sensation you have, all the practitioners have to get throughout their practice.
True, I agree. Bassam, hi, my friend. Bassam from Egypt.
Bassam, miss you.
And Mona,
hello, guys. How's everybody?
Hello, I'm sorry to say you, Alain. Bassam, you are not on my image. How are you?
How's everybody?
Mona has a list of questions for all of us. So she will ask the question, and you guys pick and choose whenever you want to answer. Mona, it's yours.
I will start now. Hello, everybody. Dr. Alain, you did great as usual, actually. And just a straightforward lecture, an amazing lecture. I will start with the private questions that's been sent to me. Now, the main drawback of piezo is a slower cutting in cortical bone when open sinuses. The question is, do you have tricks in combining piezo with other bears when you have thick cortex, or you have certain steps for thicker cortex?
For the external sinus lift, you mean, or internal?
Yes, no, external. Whatever it's like the cortex, if you have a thick cortex, is there specific steps, or do you just combine piezo with other procedures?
Well, for the people who are in a hurry, like Luis and Emad, they are too much in a hurry because they are oral surgeon. You can combine, do the rotatory instruments till you get close to the membrane, and then switch to the piezo just when you get too close to the membrane, so you avoid the tearing or the perforation. So you can combine in these cases, yes.
Yeah.
Mainly on brachyfacial patients when you have big corticals. Yes, it is indeed one of the solutions to save time. But saving complications, we are always saving time. So we got to have this in mind before we use the burrs. Because if you have one complication in 10, the time that you save with the burrs, you'll have to waste this time with the patient. So you got to think twice.
Okay.
Yes.
Question 2, please. What is your favorite sequence when doing ridge splitting? Does the piezo give a sense of safety when compared with manual splitters, especially in thin ridges of mandible?
I'm gonna let my friend Emad, he's the expert of split ridge. If I have a split ridge, I will say.
He's enjoying the question.
Thank you, Alain. How are you, Mona? It's
Hi,
good to see you. Well, actually, it's one of the most useful indications. It's the ridge splitting. I will answer part of your first question. During ridge splitting, there is no difference by using the piezo instrument or any other tool. But starting with the piezo, even with the cortical bone, you have to start all through the way with the piezo, because there's nothing that would give you a very thin cutting osteotomy except the piezo. And it's the only device that could be introduced deeply through all your split. You can go 2 millimeter by 2 millimeter. So there is absolutely no way to compare using chisels and osteotomes with this hammering and between using the piezo. It gives definitely much more safety. You feel the safety. And second, there's zero vibration in your hand, absolutely zero vibration. As we all know, as a surgeon, even general dentists, if we use rotary instruments, we should always apply reverse force to accommodate with the force that the burr is giving to my hand. So if I'm going, let's say, clockwise, I'll have to make some effort to keep my handpiece in place because it's rotating clockwise. So I may need some pressure, but using the piezo, you have a neutral effect from this matter. Absolutely zero vibration, zero neutral effect. So it's very safe, and you can go in a very precise and predictable way in doing, because ridge splitting needs very thin osteotomy. So it's one of the most important indications, definitely.
Thank you, Dr.
Dr. Emad, you want to place the implant simultaneously. Hi, Dr.
Yes.
Hi, Dr. Arwa.
Good to see you. Simultaneously. Yes, so in this case, we have to use the chisel, isn't it? Just to expand the ridge for the sake of
a little bit widen. Yes, correct.
Well, can I join in?
Yeah, sure.
First of all, hi to everybody. It's been a while, and I miss you all. Alain, you did a great job as usual, and you've covered everything in the science and technology of this tool, piezosurgery. My experience, I mean, I've been using it for the past maybe 12 years now. I'm not saying that I use it on a daily basis. As most of you know, I'm really a prosthetist that places implants and does perio or soft tissue around it. But whenever I'm doing bone grafting, and I'm going to use the piezosurgery specifically in this topic of split of the crest in the mandible, Dr. Arwa, you were asking if I'm going to be placing immediate implants at the same time. A lot of times what I like to do is split definitely with the piezo, and then maybe use these expanders instead of using the drills itself. So slowly, and for the bone, cortical bones, buccally and lingually, to expand slowly without fracturing these cortical plates. I'd rather use these expanders than use the chisels itself. I'm not really experienced so much in it. I don't do it that much, but I found that using expanders are much better and safer and minimally invasive to the patient instead of using the chisels. Alain, one of the things in sinus elevation, of course, when I'm doing, nowadays I use both, piezo and the rotary, and as you said, for us, time is money. Yes, minimally invasive. Most of us are doing a lot of minimally invasive stuff, you and I, and I'm sure everybody doing microsurgeries, soft tissue, bone, everything. But when it comes to sinus, especially the effort, I used to use the rotary a lot, and I still do. But I found that, as you said, instead of using the rotary and getting into the Schneiderian membrane and tearing it, you want to remove this effort from your mind by using the piezo. But as you said, first of all, usually what I do is I open my window with a rotary until I'm very close to the membrane, and then I continue with the piezo so I don't tear it out, and I start my elevation with the piezo itself. So basically, for me, my experience with the piezo is basically the sinus elevation, the open winding of the sinus, opening the window itself, the splitting of the crest, if you want to split, and definitely in impactions when I want to remove impacted wisdoms, and of course for the blocks. It's very, very easy, very safe, and definitely, as you said, Alain, less comfort, better healing, faster healing. I think that's the whole idea that you want to give to your patient.
Exactly. Thank you, Bassam.
Thank you.
Mona.
Yes, let's go next.
Yalla, go next.
Some implant companies, they have come up with their own sinus kits to do sinus lift procedures. Can any one of you please compare them to the piezo surgery? Like the neobiotic kits? If anyone has this.
Yeah, of course. Can I take it? Yeah.
Yes.
I made a kind of clinical study, and it was published at the EAO in 2014 about the advantages of using what they call it the intralift technique, or which is the piezo hydrodynamic sinus lift. The piezo hydrodynamic sinus lift is a technique for the crystal approach. And I have a clinical study on that on about 98. There is absolutely much higher results comparing to any other rotary tool using in the internal sinus lift. Either rotary instruments, just like the one she mentioned in her questions of the Neobiotech or any other company. I don't want the name of the company. I've used them all. The only comparable easy technique we can rely on is the osteodensification that may give you a little bit of a comfort if you follow the protocol. But for the internal sinus lift, using the piezo still is much safer, much more predictable than any other tool, either the chisels or any rotary instruments. Definitely, when you are using any rotary instruments, there is a higher risk to penetrate the Schneiderian membrane or to do any other mistake. While in piezo surgery, the main concept of the piezo surgery is this step will cut the bone and it will not harm any soft tissue around it. So take this advantage. It's the main advantage. So we have to take it to place our implants and do our surgeries in a safe way. My opinion about piezo surgery, it was a life-changing for me. I turned from being a hero surgeon, doing heroic surgeries with risk, and so I turned to a smarter surgeon. Piezo made me smarter. That's it. Turning from a hero surgeon to a smart surgeon. So doing everything safely, and the patients are taking much more comfort. As Dr. Alain Romanos said, less pain, less morbidity, safer, much more precise, and above all, we get more patient acceptance because no swelling and the healing process is much faster.
Exactly.
Okay.
Can I have a comment? I mean, while we're using implant site preparation, okay, I use the arm for drilling the healed side, let's say, not immediate implant, in a healed side. I mean, compare it to Densaber. I found Densaber really gives me, particularly in soft bone, type 3, type 4 bone in the maxilla. It will give me more confined socket, more, I mean, stable implant, or let's say ISQ stability higher using the Densaber compared to the piezo. Because although they say it does not cut the bone, it condenses the bone, but in this one, I found it's not true. So I prefer the Densaber or the Versa kit with the soft bone. What's your experience with that? Anybody?
I know Luis is a big a master clinician on the Densaber. Go ahead.
A lot. I use a lot of the Densabers, and yes, I had experienced the same. I guess I understood Dr. Arne that she was saying that preparing the site with the piezo will not densify the bone as with the Densabers, and I totally agree with that. If I have a limit case, for example, for an immediate implant, and I have like 3 millimeters of residual bone from the apex on, I will go for sure for Densabers. Maybe the initial preparation of the osteotomy, I will do it with piezo, and then I will do it with Densabers and counterclockwise, because piezo, it's much more precise for the beginning of the osteotomy, and you can go with piezo until the length of the osteotomy that you want, and then you can go with counterclockwise with Densabers. Why? Because doing this with piezo, you avoid to use the first drill, the lens drill. and then you avoid that kind of experience that we all had on the immediate implants, that you place the ball and the vibration of the burr and the bird jumps. So precisely, we prepare the initial osteotomy with piezo tips, and then counterclockwise with denser burrs, and it works very good, this protocol, for immediate implants when you have a little bit of residual. I just finished one implant before I came here. It was on a 6, on the lower 6, and same thing on the septum, first piezo until the length of the osteotomy, and then denser burrs with counterclockwise. It's my favorite protocol when I have a little, I'm in the limit to place the implant.
Great sharing this. Mona.
This is the real combination of the tools. Thank you,
As always, we have to use all these tools to give the best to our patients.
Yes.
Try to do the best.
Mona
has many questions. Go, Mona.
Okay. Can any of you please say the feeling at your fingertips when you reach the Schneiderian membrane? Can you just say the feeling at your
internal or the external sinus lift?
No, external.
Internal.
External.
Yeah.
Well, you can feel it because it's. It
can you
doesn't
feel the feeling at the tips of your fingers? Can you describe it? That was the question.
Well, when you do your osteotomy, you're removing this bone, and you can start to see through the bone, the Schneiderian membrane. So you switch to the burr where you can start to elevate, but this you can feel it. When you push against it, you can feel the membrane. This is, can be easily felt.
Another thing that I would add is, like, it's in my opinion very important, is to reduce the power of irrigation once you hit the Schneider membrane. Because if you have the power of irrigation in the maximum, sometimes you can tear the membrane, not with piezo tip, but with the pressure of the irrigation. If you have thin membrane.
Yeah, thank you. Now, how often do you replace the tips?
Very difficult question.
Actually, also an easy question from periodontics. So,
well, really,
depending how much money we made at the end of the month.
And then it depends.
That is a good month.
Yes, it depends.
Bassam, what's your opinion? When they break or after 30 use?
I think, Alain, there's not a real number about it. It's really how much you're working with it and in which areas and why you're using it for. I mean, example for the opening of the window for the sinus, definitely depends on how many times you're doing it, the size of the window, how thick this buckle wall to enter into the window, a lot of things. And of course, the force that you're using it. All of us who are using piezo and whoever is going to be starting using it, we all know we don't need to force these tips, because a lot of beginners, when they start, they're like pushing in, excited to use it, thinking they're not going to go into the Schneiderian membrane, and they start pushing, and suddenly in the first time using it, they just fractured the inserts. I guess all of us had this situation before.
I agree.
That's true. But we can visuals control if, for example, on the round tip, you can see if the diamond is still there or not. And another thing you can notice is the time that you take to do the procedures. So if you are taking much more time than usual, maybe you should change tips. Or if the bone is getting a little bit black or brown.
I've been using my experience with the VarioSurge. The investment is not as expensive as the others. So VarioSurge, nice tips, and it lasts longer. I use the VarioSurge. Mona,
first.
We have to unmute Mona. Somebody muted you, Mona, not me.
Roma is muted.
Okay, I will take a question till we unmute Mona. Somebody asked about the wisdom teeth.
It's okay now.
Can I read it?
Yes, you're in.
Yeah. What is the power in what that will be ideal for cutting a short time when making piezo incision.
Okay,
also,
let me to make the people who attended this lecture make their life easier. I have a table for each procedure, which step to use, and what's the settings that should be for all these steps. So I'll be more than happy to share this table with Tony, and Tony can email to all the participants who attended the lecture this table. So all what they have to do, just put this setting in the machine, and they can use it.
okay. Is there any other contraindication for the piezo surgeries other than the pacemaker? Contraindications?
Contraindication beside the, it's a tool, you know,
it's only if even if the practitioner has a pacemaker. So take an advantage. It's not only that the doctor has a pacemaker, and this is the only, up to my knowledge, it's the only contraindication of using it.
Right.
Maybe when you remove the implant, you should not get it in touch with the implant surface, because Ellen, you said that you use it when you remove failed implant, right?
Yes. I started recently because I'm removing so many implants, Arwa, in the last few months.
Yeah, likewise, everywhere. Likewise.
I'm removing more implant than placing.
Placing it. Yeah,
this is the problem, man.
We should have a webinar about, you know, failed implant and his technique, his own technique, his experience with removing the implant or cleaning the surface. But I found using the piezo might there will be some electric shocks if it gets in touch with, in contact with the implant surface, with specific implants, particularly the SL active surface, and create heat. So to be honest with you, I used it once, but then after that I stopped using it.
You can use it, but I try not to touch the implants. You know, if you stay away from the implant like a hair. But you're right. I've experienced the same thing because I've been using it lately more than one. You know, like multiple cases, especially when you have a lot of bone still surrounding the implant, fractured implant mainly. This is you know, it's nice. It's good to use it in these cases, of course.
Okay,
next, Mona.
Can you briefly describe the piezo tips used for lateral sinus technique?
Describe the technique using the piezo?
Yeah, the tip. If you have like steps, like or tips.
I went through the video through the sequence where you start the osteectomy, then you do osteoplasty, then you elevate the membrane, and then you switch to the manual, like to the curettes. I can share this video with the people who ask, no problem. I can send to Tony, and Tony can send to all. I have the short version, which is maybe less than a minute, but the long version is about 6-7 minutes. I can send the 6-7 minutes so they can see the tips.
Okay, sounds good. Now,
I'm sorry. I think from a piezo point of view, there are two steps. First, opening the window, as we say, like the osteotomy. And the second step is doing the detachment of the Schneiderian membrane. And each of them has its own settings on the piezo device. So
of course,
as a settings from the frequency and as a settings from the saline irrigation. So those are the main steps for from a piezo point of view, I mean.
Correct.
Dr. Alain, actually sharing Alain table for power and tips is an excellent idea. They are really appreciated from Dr. Khalid Muslim from Jordan.
Pleasure.
Okay, sir, your comment on saliva control and piezo surgeries, saliva act as good conductors of electricity?
I'm not sure. Can you repeat this, Mona? I didn't.
Yeah. Your comment on saliva control and piezo surgeries.
Saliva control?
Yeah, they said saliva act as good conductors of electricity.
Well,
comment?
Yes, if I understood well this question, piezo surgery doesn't have to do anything with any electric current that goes into the mouth. So it's just a vibrating tip. So the tip of the piezo machine is just a vibrating tip with one direction of the vibration. So there is no electricity or any electric current that flows in the mouth. So you don't have to worry about the saliva and the connectivity of the electric. What is related to the pacemaker, it's not the electricity, it's the vibration.
Yeah.
It makes contact with the, okay?
Super experience, Dr. Emad, it's obvious. Is it risky to use piezo during extraction for immediate implant because of generated heat, which may lead to bone necrosis and failure of osseointegration?
Nothing published in the literature on that, but if you irrigate very well your site, there's no reason for overheating.
Is there any difference in healing of bone with piezo? Sorry, Dr. Emad, if you...
Yes, one of the main advantages from the very valuable research that had been made by Dr. Vercellotti a long time ago, that the main advantage is that the cutting area or the exact area of the osteotomy, when put under microscope, it has a living osteocyte when you are using piezo devices. So if you don't irrigate well, or you don't put your settings, either you use a rotary instrument or a piezo, so you'll get a necrosis. But the necrosis is much less, much less by using the piezo devices.
There is another thing I'm add to this too. We all know when we place the implant, the osseointegration phase decrease in the first few weeks, and then you have a high primary stability, and then it gets lower. When they compared in the same group piezo versus conventional, they found that you have a higher primary stability with the piezo because you have less osteoclastic activity, and the shorter period of healing. So the remodeling of the bone was much faster with the piezo.
I really 100% agree with you, and I think that Dr. Christian McCarry has one day made a very nice paper about that.
Correct.
About using the
because we cause less damage preparing the site with piezo.
Yes. There's a question on the accelerated ortho treatment. Have you used it, Bassam or Emad or Luis or Arwa? Do you guys use it?
Yes, I have experience with corticotomies, not only for ortho treatment, but for example, another situation is molar intrusions. Because sometimes you're going to make full mouth rehabilitation over teeth, and you have the occlusal plane really inverted. And to intrude the molars, I found that it's super easy with it's not. I'm not using not mini implants. I use the bloqueo screws from the orthodontic surgery, and I put one screw on the palate, one screw on the buccal part, and I made corticotomies around the molars, and then elastic chain. 3 months, and you can move a molar up. Yes, it's very useful to do this kind of movements to create incisions, flapless. Because when you create incisions, you know that when you scar the bone, we are accelerating the orthodontics due to the inflammatory response. So,
how much time do you save when you use this technique?
Wow, a lot. For example, in cases of crowding. It's super useful, and I can tell you that we decrease almost 50% the time of the orthodontic treatment in this kind of cases.
No complications.
Very simple. No complications, and they are always in. The complications. Main complications is in this technique, in the corticotomies. When you're going to make big movements to the buccal, you need to graft. And this should be discussed prior with the orthodontist. Otherwise, it's better not to move. The risk is these recessions and so on. But if you proper plan it, I think that it's a powerful technique to use with orthodontics, the corticotomies. I'm a super fan of the technique.
Okay, thank you, Dr. Ali. Any specific post-operative instructions after piezo surgery?
Not at all. As the post-operative swelling and pain, it is less than with the normal surgical approach. My instructions are the same for the patients.
Okay. Another question. During ridge split and expansion using piezo, do you recommend vertical cuts?
Emad.
Yes, it depends.
It depends.
If you are doing in the
anatomic zone and the length of the split.
Yeah, it's the length of the splint, and it depends if it's in a hard bone, a cortical bone, a high dense bone, or if you have in a soft bone. In the maxilla, if you have a soft bone like a type D or D3 or D4, I rarely use a vertical cut. But in the mandible, I always use a vertical cut. And I add for, as Dr. Bassam said, the controlled screw expansion combined with the split technique.
Exactly.
And
if I can add my 2 cents about the split technique, never perform split technique without a good kit of fixation screws on the office, because you can left your patient worse than you start the surgery.
Yes.
So for me, it's mandatory to have screws in the office to make expansions, mainly in the mandible, because in the mandible it is less predictable, and in small spaces when you need to do vertical cuts, this is the kind of the kind of anatomic situation that sometimes you can experience troubles. My preference when I got, for example, on a 6 to make an expansion is to cut to take it out, all the buccal bone, to invert the buccal bone, because the apical side is normally thicker, invert the apical bone and do like a Corey technique, and it works really amazing.
Okay, can you please describe briefly using piezo for mandibular impacted third molars?
For the third molars, well, instead of using burrs, we can use the cutting insert. So we basically use the same procedure as if you're removing wisdom teeth with the regular burrs. So you do your ostectomy around the implant if you have to do root separation depending on the position of the wisdom tooth, but especially in areas where you're close to the nerve or proximity with the adjacent tooth, this is a beautiful tool to have and safer.
Okay. What can you do if one of the tips is broken inside the surgical site? Is it that easy to be removed?
Yeah, most of the time, yes. If you use a small suction tip, you can go after it and remove it, yes.
Okay, and another question I ask, which piezo you find most efficacious? More, it's like, which I cannot really ask, read the question. So which kind of, or which type of piezo you prefer to use in your surgeries?
Which type of piezo?
Yeah, although it's person to person.
Let me tell you one more tip. I personally use the NSK, the Vario Surge. This is my favorite, but I'm gonna give one tip to the people who are planning to use piezo. The piezo, and if you want to use it, you have to have it ready. It has to be on your surgical field, open, ready to go. If it's in the box in a different room, you will probably not feel, you will not feel like the motivation to go open it, put your tips, make everything, because this is going to take 5 minutes, and you're not going to have this motivation to do so. So my advice to you guys, if you want to use it, you have to have it ready to go. Just open the insert, plug it in, and get to work. This is my opinion. Arwa.
Totally agree with you.
Unmute Arwa. We need to unmute Arwa. في بعض questions منى على الchat.
Almost two.
Do we answer all the people or still have some?
No, still I have some questions actually.
يلا shoot.
Yalla. Is there a specific angle to use the tips?
Some of the tips have already different angles. So if you want to go do block on the ramus, some of these tips are already angled. So you don't have to.
the basal stops.
Exactly.
But you have to be careful it doesn't break. Some of them, they're so thin, as Dr. Mona said in one of the questions, it gets breaks easily, particularly if you exert pressure.
I can tell a really funny story if you want. I was seeing your presentation, Alain, and you were seeing the Taurus. And 3 years ago, in my mother-in-law, I need to perform a sinus lift. Yeah,
it always happened with the mother-in-law.
Sinus lift. But I like her. We are good friends.
Not like mine.
Naughty Alain.
Sinus lift and vertical augmentation on the same site. So she had the Palatin Taurus, and I said, okay, this will be my source of bone, my source of autologous bone. And she was laid down on the horizontal, and I just put anesthesia, opened the flap, opened the Taurus, and I got 2 boxes of the same inserts. And I say, these are these. I say, this, just kidding, you know? I put the insert, I've done like this, 3 seconds. And she was laid down like the mouth open. And my friend that was with me, it's an experienced surgeon as well. She started to take out the gum in the mouth to search. I say, I didn't feel it. Man, I was sweating all the surgery. I finished the surgery. I say, hey, Marco, please come on here. I need to talk with you. Something happens and we need to go to the hospital. What? Go to the hospital? Are you crazy? It's the birthday of your father. Let's go to the parties like this. I said, I was in shock. I said, look, Luis, please, can you tell your mother that we need to go to the hospital? Something could happen. No, I will not go to the hospital. Was one of the worst experiences of my life.
It's good that it happened to your mother-in-law.
Yeah. Imagine, my friend. I was really sweating all the surgery, but at the end, everything went good, and she took it off. And no.
Bassam, something happened to his mother-in-law as well too. No, Bassam?
No. No, actually, let me tell you one thing about sinus elevation. I mean, funny story too. That was like maybe 11 years ago. I was doing an open sinus and using the piezo. Opened everything, the window beautifully, elevated, everything is fine. I'm preparing my bone on the side and the membrane. And while I'm preparing, I'm telling one of my assistants, suction. So unfortunately, he put the suction tip at the window inside. And all I heard while I'm not looking is, that's all I heard. And you can understand what happened. He suctioned the whole Schneiderian membrane. So in that time, I mean, piezo doesn't help at all.
Can I make a small comment? Can I make a small comment on the question that Dr. Mona Abbadi asked? Is that how frequent you could get a breaking of the instrument? All the piezo tips, we have to know that each procedure with piezo device, they have their own special tips for performing this kind of procedure. So if you use each instrument for the purpose that it was manufactured for it, you'll get a safe surgery. I mean that you shouldn't use the extraction tip of the piezo for taking, doing the osteotomy of the sinus. So there's a sinus lift kit, there's a bone surgery kit, there's a bone splitting kit.
Exactly.
And the extraction kit. So just, it's not only the machine. You have, each practitioner have to buy the kits which are suitable for his kind of surgery. Okay, so don't use either tips for another kind of surgery, so you get much less risk of fracturing or misusing or not using correctly.
Okay. Now, dear doctors, I have to end with this question as Dr. Tony asked me because we are running out of time. Actually, we have too many questions and I believe that people, they are enjoying the discussion. So, Dr. Walid from Lebanon, I would like to ask about indication of piezo in primary immediate implant placement and also anterior implant placement in thin biotype cases to avoid use expander techniques. Can we expand by piezo and can we reduce the use of bone graft materials in these techniques?
Piezo, you cannot, the piezo is just a tool. It makes your life easier and less invasive to the patient. But this is not gonna compensate for cases where you're gonna need bone augmentation or thin or thick biotype. It's not, it's a complete different story. In the immediate implant, I'm like Arwa said and Luis, I'm moving more and more toward osteodensification technique when it comes to placing implant in the aesthetic zone to have a higher primary stability. But to answer these questions, no, actually it's not an indication to avoid bone grafting techniques.
Okay. Now, most of the questions actually, they were about the tips. How to prevent your tip from getting any like, fracture during the surgery. Do you have any recommendation?
A lot of irrigation, not much pressure on the tip because you don't want to put too much pressure. And I will share with Tony the settings because you have to be using the settings for each procedure. You cannot use for cortical bone a setting for soft bone. So each of these tips has a setting that you have to introduce to the program of your machine. And what I did personally is I have many programs in the various source. So for each procedure, I just put the setting one time, and every time I have a case, I would just put the program and go for it. You know.
Okay. Now I will let this question actually pass because I like what he's mentioning. He's saying that the narrow implant diameters, they are nowadays, they are like, you know, they are successful and they are there for several years. So do you think that this will put the bone split outdated? So splitting the bone is not performed anymore if you are going to go for the narrow implant diameters?
It depends on the case and depends on your, the question is not about placing implant, it's about placing a proper implant prosthetically. So really there's so many factors that plays into, but we still do split ridge, we still do narrow implant, we do all these procedures. So depending on the case.
I believe narrow implants, they won't work at the posteriors, no? So still we have to go for the splitting technique.
Honestly, I personally don't place narrow implant in the posterior molar area because this is where I'm removing fracture implant.
Yeah, most of the cases, the fractured ones, they are the posterior, narrow. Yes. So I think we have to end now. And thank you, everybody. Thank you, Dr. Alain, for the amazing lecture. And thank you all for the nice discussion. Nice to see you all, and looking forward for another webinar, Dr. Alain.
Great pleasure to be with you all. I miss you all, and I hope once we finish with this Corona break, we get to meet for a long vacation.
We got to meet.
We all go to Bassam at Sharm el-Sheikh diving.
Wow.
Actually, this is a question for Dr. Bassam. What did you do after the Schneiderian membrane has been sucked by the suction tip? What did you do?
Unmute. We have to unmute Bassam. Unmute. Somebody has to.
Can I say?
Yes, go ahead, Luis, because Bassam is muted.
Close the flap and go home sleep. It's a better way to recovery of this.
Great. Thank you, Mona, and Arwa for hosting us, for leading this conversation. It's a great pleasure. If any of the participants still have questions, please feel free to email me or to text me on the Facebook or Instagram page, and I'll be more than happy to answer any unanswered questions.
Okay, thank you, Dr. And thank you, Dr. Tony Deep, for such a nice organization. And thank you all.
Thank you.
Thank you so much. Hope to see you all soon.
Thank you.
Night.
Bye-bye.
Have a great weekend. Bye-bye.